Hello and welcome to this presentation on ERCP tips and tricks, difficult biliary cannulation. I am Dr. Monzahmed, consultant gastroenterologist at Good Hope Hospital in the United Kingdom. Let us first of all look at the anatomy of the papilla and ampulla of Vata. This structure is formed at the union of the common bile duct and the main pancreatic duct and is situated in the second part of the duodenum. If we look at the diagram on the right, we can see that the common bile duct has a vertical trajectory as it approaches the duodenum. In contrast, the main pancreatic duct has a more horizontal trajectory as it approaches the duodenum, and where these two ducts meet, there is a common ampullary channel which then opens into the lumen of the duodenum. This structure is guarded by a sphincter known as the sphincter of Oddi, which is composed mainly of circular muscle fibers, but in addition there are longitudinal fibers and reinforcing fibers which come from the duodenal wall. Part of the sphincter of Oddi encircles the common ampullary channel. Part of the sphincter encircles the lower part of the common bile duct, and part of the sphincter encircles the lower main pancreatic duct. There is this muscular septum which separates the lower common bile duct from the lower main pancreatic duct. Now, we often use the terms papilla and ampulla interchangeably, but they do not mean the same thing. The papilla is the elevation on the duodenal mucosa that we observe when we look at the structure at ERCP. It is a bump on the duodenal wall. In contrast, the ampulla is the dilatation at the confluence of the bile duct and the main pancreatic duct. It is found within the papilla, and normally we cannot see it when we do ERCP. The boundaries of the papilla is shown by this dotted green line. The structure of this region is subject to anatomical variations. Indeed, there are at least 4 well-known variations in anatomy which are termed Y, V, U and Roman letter 2 or double-barreled configuration. In the Y configuration, the common channel measures at least 1.5 millimeters in length. In the V configuration, the common channel measures less than 1.5 millimeters in length. In the U configuration, there is no common channel and the two ducts open separately but at the same orifice. Finally, in the double-barrel configuration, again the two ducts open separately but each has its own papilla. The relative prevalence of these 4 variations are 61.2% for Y, 14.3% for V, 22.4% for U and 2.1% for the double-barrel configuration, and these figures are derived from a study by Flatty et al. In 1994 when they looked at approximately 100 pathological specimens of the duodenum. Let us now look at the optimal ways of cannulating the bile duct and the pancreatic duct. This diagram is divided into 3 sections. The upper part of the diagram shows a sagittal view of the papilla, with the common bile duct in green and the main pancreatic duct and ampulla in pink. The middle diagram is a transverse section through the duodenum with the anterior duodenal wall on our right, the posterior wall on our left, the medial wall at 12 o'clock and the lateral wall at 6 o'clock. And again, the common bile duct is in green and the pancreatic duct is in pink. The lower diagram shows the papilla as we would see it at ERCP, with a clock face drawn around it, and the papillary orifice is magnified on the left. Let us now look at the optimal trajectory for cannulating the bile duct. We have to attack the papilla at a steep angle so that the cannula is parallel to the direction of the common bile duct. The scope has to be fairly low in the duodenum and is usually situated either in the midline or slightly anteriorly so as to optimize the axis of cannulation. The point of contact on the papillary orifice is the left upper quadrant, and the wire or cannula should be directed towards the 11 to 12 o'clock sector as observed by the ERCPs. These maneuvers all optimize the direction of cannulation so that the cannula is in the same axis as the duct. In contrast, when we try to cannulate the pancreatic duct, the angle of attack is shallower. This is because the main pancreatic duct has a shallower trajectory compared to the common bile duct. The scope is inserted to a shallower depth in the duodenum, and the position of the scope should be midline or slightly posterior to the midline, again to optimize the direction of cannulation. The point of contact should be on the right side of the papillary orifice, and the direction in which the cannula is to be aimed should be between 1 o'clock and 4 o'clock as observed by the ERCPs, typically towards 2 o'clock or 3 o'clock. Standard cannulation may be divided into contrast-assisted cannulation and guidewire-assisted cannulation. With contrast-assisted cannulation, we place the tip of the cannula into the common channel and gently squirt a small amount of contrast to opacify the ducts, and then adjust position to get selective cannulation. With guidewire-assisted cannulation, we use a wire to selectively cannulate the desired duct and then follow through with the cannula. The guide wire method may be further subdivided into touch or no touch, depending on whether the tip of the cannula makes contact with the papilla before the wire is inserted. And of course, we can use features of both of these methods and come up with a mixed or hybrid technique. At least 4 meta-analyses have been performed looking at the merits of contrast-assisted cannulation versus guide wire assisted cannulation, and the overall consensus from these meta-analyses is that guide wire assisted cannulation is superior in terms of cannulation success and a reduced frequency of post-ERCP pancreatitis. Using standard cannulation techniques, we should be able to enter the bile duct in 80% of cases. This means that in about 20% of cases, we fail to achieve biliary cannulation using standard techniques. And the longer we attempt to get into the bile duct, the higher the risk of complications, such as post-ERCP pancreatitis and bleeding. And of course, by delaying cannulation, we delay potential therapy. So what constitutes difficult biliary cannulation? The ESGE guidelines from 2016 define a difficult biliary cannulation as one which takes more than 5 minutes, or one where there is more than 5 attempts at biliary cannulation, or if there is unintentional pancreatic duct cannulation or opacification on more than one occasion. So these criteria are rather strict. In another set of guidelines called the International Consensus Guidelines 2017, the authors define difficult biliary cannulation as one where the duration of the attempt is more than 10 minutes, or if there are more than 5 attempts needed, or if there is failure to access the major papilla. These guidelines from 2017 do not mention unintentional pancreatic duct cannulation. So what makes cannulation difficult? Well, the factors may be divided into operator dependent and patient dependent. We know that the experience of the operator is important, and we've already seen that guide wire assisted techniques may be better than contrast assisted techniques. Patient dependent factors include anatomical considerations such as the size, morphology and orientation of the papilla, the presence or absence of duodenal diverticula, and previous surgery such as Billroth 2 or Rouen Y. There are certain maneuvers that we can use to facilitate selective biliary cannulation in difficult cases. First of all, we have the long scope position. Now usually we prefer the short scope position, where the scope lies along the lesser curve before it enters the duodenum. This is more comfortable for the patient, and it means that the control of the scope tip and instruments is better. However, in certain situations, adopting a long scope position may be helpful. This is where the scope runs along the greater curve of the stomach before entering the duodenum. This is more uncomfortable for the patient because it stretches the stomach, but it may allow us to visualize the papilla in certain situations, particularly if the papilla is very proximal or very distal in the duodenum. Another simple maneuver that we may use to facilitate biliary cannulation is a change in the patient's position from the standard ERCP position to, for example, a left lateral decubitus position or a supine position. This simple change of position may improve the orientation and scope stability in some patients. Now let us look at the specific maneuvers to facilitate selective biliary cannulation in difficult cases, and this is the main part of this talk. These maneuvers may be divided into pancreatic duct assisted techniques, Precut assisted techniques, endoscopic ultrasound assisted techniques, and traditional percutaneous rendezvous. I will be discussing mainly the first two techniques, that is pancreatic duct assisted techniques and Precut assisted techniques. With pancreatic duct assisted techniques, we place either a guide wire or a stent into the pancreatic duct before cannulating the bile duct. And I will discuss both of these methods in a few minutes. With Precut assisted techniques, we use either a needle knife or a sphincterotome to cut the papilla in a variety of ways to facilitate biliary cannulation. And these methods may be subdivided into Precut papillotomy with needle knife, Erlangen Precut, Precut fistulotomy with needle knife, Transpancreatic Precut sphincterotomy, Precut over pancreatic duct stent, and the Burdick technique. And again, I will discuss all of these 6 techniques in a few minutes. However, I will not be discussing EUS assisted techniques such as suprapapillary puncture in combination with EUS and EUS guided rendezvous methods. Neither will I be discussing traditional percutaneous rendezvous techniques. Let us now look at the first of those specialized techniques, the pancreatic guidewire technique, often known as the double guidewire technique. Here I have again used the diagram from the beginning of the talk, showing a sagittal section through the papilla. Using the pancreatic guidewire technique, a first wire is placed into the main pancreatic duct. Often this wire is placed inadvertently because it keeps finding the pancreatic duct rather than the bile duct. We leave the wire in situ and come out with the sphincterotome. We then try to cannulate the bile duct using either the sphincterotome on its own, in which case it's called single guidewire technique, or more usually by using a second wire, which is shown in red. If we use the second wire, it's called the double guidewire technique. The idea is the first wire obturates the main pancreatic duct and also straightens the intraduodenal portion of the common bile duct, thereby facilitating entry into the common bile duct with the second wire. A meta-analysis by C et al. In 2017, looking at 7 randomized controlled trials, showed that the double guidewire technique increases the post-ERCP pancreatitis rate with a relative risk of 1.98. Hence, if we use this technique, then it is recommended that a pancreatic stent is inserted afterwards so as to minimize the risk of post-ERCP pancreatitis. Here is an example of the pancreatic guidewire technique using 2 wires. It's a difficult papilla on the edge of a diverticulum. The first wire is within the pancreatic duct. We have the cannula here, and we're attempting to enter the bile duct over the first wire. the tip of the cannula is inserted into the common channel just above the first wire. A second wire is then passed through the cannula, and it has found the common bile duct as shown by this arrow here. Once the second wire is within the common bile duct, we follow through with the cannula and then we inject contrast, and here we can see a stone in the lower common bile duct. We can then continue with the procedure, perform a sphincterotomy and remove that stone. A variation of the pancreatic guidewire technique is the use of a pancreatic stent assisted cannulation. Instead of leaving the wire in the pancreatic duct, we place a pancreatic duct stent and then remove the wire. We then use a sphincterotomy with or without a wire to achieve common bile duct cannulation. The disadvantage of this method is once a pancreatic duct stent is placed, this orifice becomes rather narrow, and it may be difficult then to place the tip of your sphincterotomy in the common channel. It can be done, but it is quite a difficult procedure, and sometimes you may need to widen this gap with a needle knife, and I'll show you how to do that a little later in this talk. This brings us to the various Precut techniques, and these techniques are summarized in this slide. First, we have Precut papillotomy using a needle knife. Then the Erlangen Precut, which employs a short-nosed sphincterotomy. Thirdly, we have Precut fistulotomy using a needle knife. Then there is the Transpancreatic Precut sphincterotomy, also known as septotomy or Goff technique. Then we have Precut over a pancreatic duct stent, as alluded to in the previous slide. And finally, we have this unusual technique known as the Burdick's technique. I will now show you each of these 6 methods. First, we have Precut papillotomy with a needle knife. In this technique, we use a needle knife to make a small incision at the papillary orifice. This incision can be made either in an upward direction, starting at the papillary orifice and moving the knife upwards, or alternatively it can be made in a downward direction, starting just above the papillary orifice and cutting downwards. The idea is to widen the entrance of the papillary orifice, thereby facilitating insertion of a wire or a cannula into the bile duct. Here we see an example of Precut papillotomy using a needle knife. In this attempt, we failed to enter the bile duct after 5 minutes, so we have brought out a needle knife to perform a Precut. In this example, I will be cutting in a downward direction, starting just above the papillary orifice here, and then cutting downwards towards the papillary orifice. Once the cut is made, we probe the apex of the cut gently with a guide wire. And once the wire is in the duct, we follow through with the cannula and then inject to opacify the bile duct, as shown here. The next procedure is called Erlangen Precut, after the famous city in Germany, which was a hotbed of ERCP activity in the early days. In the Erlangen Precut, we use a short-nosed sphincterotomy to achieve shallow cannulation of the common channel with the tip of the sphincterotomy. We then make a small cut, 1 or 2 millimeters in length, just at the entrance of the papilla. In effect, this achieves the same result as a needle knife Precut. The idea is to change the shape of the papillary orifice from a circle to a teardrop, and then we attempt to cannulate at the apex of the teardrop. The best sphincterotomy for this procedure is one with a short nose like this one, or a slightly longer nose like this one, but not this sphincterotomy which has a very long nose. Here is an example of Erlangen Precut using a short nose sphincterotomy. The papilla is a difficult one and is inside a diverticulum. The papillary orifice is situated awkwardly. First of all, the tip of the sphincterotomy is placed in the common channel and the wire is bowed so that the distal portion of the wire makes contact with the roof of the papillary orifice. We then apply diathermy current to make a small cut at the entrance of the papilla. The tip of the sphincterotomy is then adjusted and a wire is passed into the bile duct here. We then follow through with the cannula and inject contrast to opacify the duct. The next technique is called Precut fistulotomy. In this technique, we use a needle knife to make a suprapapillary fistula well above the papillary orifice. We make stepwise incisions until we reach the bile duct, and then a wire is passed into the duct and the cannula is passed over the wire. Here is an example of Precut fistulotomy. In this example, we've been unable to enter the bile duct after 8 to 10 minutes, and the pancreatic duct has been accessed with the wire 3 or 4 times, but the wire has fallen out. You can see the papilla is bulging, and it is said that this is the ideal shape of the papilla for this technique. So we make the cut in a stepwise fashion, and the position of the cut is above the papilla. After the initial few strokes, I am attempting to probe with a wire, but unfortunately the bile duct is not accessed. So we need to cut a bit more. Sometimes we are rewarded by a trickle of bile. I think there was a trickle of bile there. We then try again with the wire. And on this occasion, the bile duct is cannulated easily. Once cannulated, we can opacify with contrast. And in this case, there is a stone which can then be dealt with. The next technique is called Transpancreatic Precut sphincterotomy. It is known by several other names, including septotomy and the Goff procedure, after the endoscopist who first described it in 1995. The ideal shape of papilla for this technique is a small papilla or a small flat papilla. At first sight, this diagram looks a bit like the Erlangen Precut, but it is not the same as the Erlangen Precut. With the Goff method, the sphincterotome is placed deeper into the main pancreatic duct, not the common channel, and often the sphincterotome is placed over a guidewire which is in the main pancreatic duct, not shown in this diagram. When we apply diathermy, we cut not only the ampullary sphincter but also the septum separating the common bile duct from the main pancreatic duct. Once the septum is cut, we can then achieve cannulation of the common bile duct because the septum is no longer getting in the way of cannulation. Some early studies showed that the bleeding and pancreatitis rates for this procedure are rather high, and so it is recommended that a pancreatic stent is inserted if this method is used. This short video shows an example of transpancreatic precut sphincterotomy. Here, a double wire technique is first used, but the second wire keeps entering the pancreatic duct. So we now attempt transpancreatic sphincterotomy over the wire. The septum is cut and the cut is then extended. A second wire is now inserted into the bile duct and the cannula then passes through. A stone is seen. A biliary sphincterotomy is now performed. A 5 French pancreatic stent is passed over the first wire and a balloon is used to remove the stone. The next method is precut over a pancreatic stent. We have shown previously that if you put a pancreatic stent in before cannulating the bile duct, then the entrance of the bile duct is narrowed. To widen it, we can use a needle knife to cut down onto the stent and then cannulate the bile duct after this precut. In this example, the papilla is bulky. We managed to get into the pancreatic duct and we placed a pancreatic stent. A precut is then attempted with the stent in place. So we cut from just above the stent onto the stent. Once the cut is made, we can achieve biliary cannulation. In this example, there's a stricture which is then stented. The final method involving cutting is the Burdick's technique, which was described by Burdick et al. In 2002. They described 6 cases where an inadvertent false passage was formed in the 10 to 11 o'clock direction whilst attempting to cannulate the bile duct. an intramural incision was made to deroof the papilla, exposing the submucosal structures. The common bile duct was then cannulated after this exposure. Here is a video example. So whilst attempting biliary cannulation, a false passage is created. You can see a wire which has passed through a false passage and has come out into the duodenal lumen. The idea with the Burdick's technique is to cut the mucosa above the papilla. And by so doing, we expose the submucosal structures. So after deroofing the papilla, we then attempt to cannulate the bile duct using a wire-assisted technique. And you can see the wire here in the bile duct. The cannula is then followed through, and contrast is injected, showing a stone in the lower common bile duct here. Since the original description by Burdick, there have been 3 further studies using this technique. The overall success rate ranges from 75% to 100%. Some complications have been reported. In the original study, there was 1 case of post-ERCP pancreatitis amongst the 6 patients. In the second study, there were 4 complications amongst the 16 patients, with 1 bleed, 2 episodes of cholangitis, and 1 extravasation of contrast. In this study by Misra, there was 1 case of post-ERCP pancreatitis amongst the 23 patients, and in this larger series of 34 patients, there was 1 procedure-related bleed. So how do these advanced techniques compare against each other? In 2019, Pexi et al. Published a meta-analysis comparing 4 of these techniques, that is transpancreatic sphincterotomy or Goff method, double guidewire technique, needle knife precut papillotomy, and needle knife fistulotomy. In this first graph, we look at cannulation success. The upper graph compares transpancreatic sphincterotomy with double guidewire technique, and it was found that the transpancreatic sphincterotomy was superior. The second graph compares transpancreatic sphincterotomy with needle knife precut papillotomy, and again the transpancreatic sphincterotomy was superior. The third graph compares transpancreatic sphincterotomy with needle knife fistulotomy, and the 2 procedures were similar. So the overall message from this meta-analysis is transpancreatic sphincterotomy is superior to double guidewire technique and needle knife precut papillotomy, and is similar to needle knife fistulotomy in terms of cannulation success. In terms of post-ERCP pancreatitis, transpancreatic sphincterotomy was no different to needle knife precut papillotomy or double guidewire technique, as shown by the first 2 diagrams. However, transpancreatic sphincterotomy was worse than needle knife fistulotomy, as shown by the third diagram. And finally, in terms of bleeding and perforation, all 4 techniques were broadly similar. The bleeding and perforation rates did not differ very much amongst the 4 techniques, with the black diamond placed centrally in all the charts. So when do we use these advanced techniques to enter the bile duct? Well, the ESGE guidelines from 2016 help us to decide. We should first of all use standard techniques to achieve biliary cannulation. If we fail to do so after 5 attempts or after 5 minutes, we should then move on to one of these more advanced techniques. If there is a wire in the pancreatic duct placed unintentionally, we should consider pancreatic stenting either immediately or at the end of the procedure. We should first of all try to achieve biliary cannulation using pancreatic guidewire assisted techniques, either the single wire technique or the double wire technique. If this fails, then the options include fistulotomy or transpancreatic biliary sphincterotomy. A fistulotomy is favoured if the lower common bile duct is bulging, whilst a transpancreatic biliary sphincterotomy is favoured if it is not bulging and if the papilla is small and flat. If there is no wire in the pancreatic duct, then the options include fistulotomy or one of the Precut techniques using either a needle knife or a short-nosed sphincterotome, depending on if the common bile duct is bulging or not. If it is bulging, then a fistulotomy is favoured. If fistulotomy or Precut fails, then the options include repeat ERCP, and we should consider antegrade guidewire assisted cannulation. If you are going to use transpancreatic biliary sphincterotomy or fistulotomy, then the ESGE guidelines advise that you should be an expert endoscopist. Also, it is advised that if a wire has been placed in the pancreatic duct, then a stent should be placed to minimize the risk of post-ERCP pancreatitis. This brings me to the end of this talk. Thank you very much for your kind attention.